Dr. Simon Kigondu is an experienced gynecologist with over 15 years of practice. He will be presenting on endometrial ablation in Kenya and how he intends to reposition. Karibu daktari.
As I said, Dr. Kigondu is my name. I'm the chair of COG Central branch. I also double up as I have a private clinic in Nairobi called Exela Healthcare. I also am the gynecologist at Kigumo Sub-County Hospital. Yeah. Murang'a County is where Meru County needs to come for benchmarking for obstetrics and gynecology. Kigumo Sub-County Hospital is where I am. I'm not an expert in gynecology, so to speak, in terms of things like endometrial ablation. Me, I like the perineum. I like seeing babies coming out, nachomoa, clamp the cord, and obstetrics is my forte. And removing in Murang'a, we have very big fibroids, and removing big fibroids. These are the things we leave to people. But while I was in Rwanda, the ministers had organized there's a team from Hologic that had organized a very big meeting of a lot of machines about endometrial ablation, those kind of things for the ministers in Kenya. And I got very interested in what they were doing. And for this particular Congress, we were actually supposed to have some form of training on endometrial ablation, because this company called Hologic, of which Hudson seated behind there, will come and just give a short brief about it. I became interested because the question I was asked, for management of abnormal uterine bleeding, how many of you people do endometrial ablation? So najua sisi kama watu wa Murang'a, sisi when you start having uterine problems, we remove your uterus, you solve the problem once and for all. But of course there are those areas where you may need to leave your uterus intact, some ladies like that. So I just thought of a quick small presentation just before Hudson tells us about some of the equipment they use for various things, including endometrial ablation, and he has promised to organize some training on it's common, and it's a complex, and it's bleeding from the uterus that is abnormal in volume, regularity, or timing, and has been present for at least also, and generally everyone who has seen abnormal uterine. And the impact of abnormal uterine bleeding is very big. It's anemia, reduced quality of life, productivity, and over-reliance of long-term medication. And also now necessitating hysterectomy or surgical intervention. As you know, FIGO have sort of helped classify AUB. So they coined the term palm-Korean, which if you go through the structure is leiomyomata, malignancies, and hyperplasia. Then there are the physiological factors of coagulopathy, ovulatory dysfunction, and endometrial functions, and iatrogenic things like giving medication that can cause you to bleed. So how you diagnose AUB is through the usual history, physical examination, and investigations. So we have several pre-interns in the house. This is how unaanza na diagnose, history, physical exam, and investigations. Someone does not come bleed, then you send them for ultrasound first. Yeah. And there are several investigations that are done to do that. Now we come to this, what was of interest to me, something called the endometrial ablation. What is it? It is the surgical destruction of the endometrium, whose goal is to reduce or stop excessive menstrual bleeding. It's ideal for women with no future fertility plans or have failed medical therapy. And what types of endometrial ablation exist? There is non-resectoscopic NRA, which are office-based, easy learning curve, easy to learn. Then there are the resectoscopic REA. They need outpatient setup, theater setup, and they need more surgical skill and a bigger cuff. So what are the benefits of ablation? They are minimally invasive. They have a short recovery time. They have high patient satisfaction and reduced need for hysterectomy and long-term cost savings. So what is the global practice vis-a-vis the local practice? How many gynecologists here have done endometrial ablation? Dr. Were, only, you see? And here there are many gynecologists. Now, Wakubwa, kama Gatumi, Gyne Onko, Eli Odongo has not done endometrial. So it is something to think about. It is not something we are pushing, but, have you ever thought about it? As in, someone with AUB, you can actually, just ablate the endometrium, leave the endometrium alone. So it's an interesting, this is just for thought-provoking. The barriers to these are, of course, equipment. I'm sure they are technical equipment. There is limited training. If only one gynecologist here has done that, you are unlikely to have any other people doing that after that. And probably lack of awareness, which is what I have brought up here, so that maybe we can stimulate a discussion on endometrial ablation. So elsewhere, the clinical practice, especially I was informed that in America they do that a lot, has 70 to 90% reduction in the bleeding. Amenorrhea occurs in up to 70% of those treated, and they report a low complication rate of 2%, and the patient satisfaction is over 85%. So how do you do patient selections? Ideal AUB are done, those who have done with childbearing. For the pre-interns, you need an endometrium to get pregnant, you get the point, or for the baby to grow inside there, and you need a normal uterus. It's contraindicated in those who desire fertility or who have cancer, or anatomia early, have distorted the endometrial cavity, or have infection. The factors that influence success are the uterus should be about less than 10 weeks in size, absence or treatment of other intercavitary lesions, fibroid na vitu kama hiyo, less over 35 years, and clear patient expectations. What do they want? Then they just don't want to bleed. Then training and capacity needs should be included in residency. I don't think we ever saw in residency any endometrial ablation. Daktari, muliona endometrial? Anyone seen? Yeah. Then workshops and practicing for practicing OBGY. We were actually to do a workshop here, but some of the machines, as Hudson will tell us, were not able to get clearance for that. And investing in hysteroscopic skills and create sectors of excellence. I think there's a lot of hysteroscopy work and minimal access work that is going on. Then, of course, these systems are costly and make access difficult. So we need to advocate for tax exemptions for some of the machines. We need to push for NHIF SHA insurance coverage and device sharing and having pilot programs on the same. So our call to action here is we need to educate our patients so that you can have demand driving. We need to request access at these hospitals, have joint advocacy, COGS, KMA, and other professional associations, and generate local data and publish outcomes. Then we need to partner with the experts. So in conclusion, endometrial ablation is safe, effective, and underused, actually not used at all, in Kenya. Maybe we can improve this for access to Kenyan women.